More than 200 million people worldwide take a statin pill. It's one of the most prescribed medications in human history. But every week, patients come to their doctors with the same question. Are statins actually safe? Should I really be taking this? Today, we're cutting through the noise, the myths, the headlines, and the fear to give you a clear, evidence-based answer. By the end of this video, you will understand what statins do, who genuinely benefits from them, what the real risks are, and how to have a smarter conversation with your doctor. Statins sit at the center of one of medicine's biggest controversies. Not because the science is unclear, but because the media, social media, and even some doctors send conflicting signals. Some headlines call them lifesavers. Others call them dangerous. The truth, as usual, lies in the details, and that's exactly what we're going to explore together. Statins work by blocking an enzyme in the liver called HMG-CoA reductase. The enzyme your liver needs to produce cholesterol. Less of this enzyme means less LDL cholesterol being made. LDL, often called the bad cholesterol, is the primary driver of fatty plaques building up inside your arteries. When those plaques rupture, they trigger blood clots, and that's what causes most heart attacks and strokes. So by lowering LDL, statins reduce the fundamental biological process behind cardiovascular disease. There are several statins on the market, and they're not all identical. They differ in how powerfully they lower LDL, how they're processed by the body, and their side effect profiles. Atorvastatin and rosuvastatin are the most widely used because of their high potency and once-daily dosing. Importantly, generic versions of most statins are now available, making them affordable even without insurance in most countries. Here's something many people don't know. Statins don't just lower cholesterol. They also reduce inflammation in the walls of arteries, stabilize dangerous fatty plaques so they're less likely to rupture, and improve the overall function of blood vessels. These additional benefits, called pleiotropic effects, may explain why statins may also have additional beneficial effects beyond LDL reduction. Current guidelines identify several groups who benefit clearly from statin therapy. These include anyone who's already had a cardiovascular event, people with diabetes age 40 to 75, and those with familial hypercholesterolemia, a genetic condition causing very high cholesterol from birth. For everyone else, the decision is based on your calculated 10-year cardiovascular risk, using tools like the ACCHA Risk Calculator, or Q, Risk 3 in the UK. If your 10-year risk is above about 7 to 10%, guidelines generally recommend discussing statin therapy with your doctor. The most talked about side effect is muscle pain, called myalgia. And yes, some people do experience genuine muscle aches on statins. Studies suggest around 5 to 10% of patients report this, though large blinded trials show a much lower rate, sometimes only 1 to 2% above placebo. There's an interesting phenomenon called the nocebo effect, where patients who expect side effects are more likely to report them. Serious muscle damage, called rhabdomyolysis, is extremely rare, occurring in roughly 1 in 10,000 patients. If you develop severe, unexplained muscle pain or dark urine while on a statin, see your doctor immediately. This is a real risk that deserves honest discussion. Statins do modestly increase the risk of developing type 2 diabetes by about 10 to 12% in relative terms. In absolute terms, that translates to roughly 1 extra diabetes diagnosis per 200 patients treated over 4 years. This risk is concentrated almost entirely in people who already have prediabetes or other metabolic risk factors. For the vast majority of patients who are recommended statins, the cardiovascular protection they provide far outweighs this modest increase in diabetes risk. But it does reinforce the importance of lifestyle measures, healthy diet, and exercise, especially for those at metabolic risk. You may have heard claims that statins cause memory loss, liver failure, or even cancer. Let's address these directly. Large randomized controlled trials and meta-analyses have found no evidence that statins cause cognitive decline or dementia. In fact, some studies suggest they may be protective. Serious liver damage is extremely rare, and routine periodic monitoring is no longer recommended after baseline testing. There is no credible evidence from large trials linking statins to cancer. These claims circulate widely online, but they are not supported by the weight of scientific evidence. One of the most useful tools for understanding drug therapy is the concept of NNT, number needed to treat, and NNH, number needed to harm. For a patient who has already had a heart attack, you may only need to treat 20 to 30 people for 5 years for one cardiovascular event to be prevented. For a low-risk individual considering statins for the first time, that number may be over 200. Meanwhile, you need to treat around 10,000 patients to cause one case of serious muscle damage. This framework makes clear why high-risk patients have strong reasons to take statins, while low-risk patients should have a detailed conversation about individual circumstances. This is one of the most important concepts in medical literacy. When a study says statins reduce heart attack risk by 25%, that sounds dramatic. But if your baseline risk was only 2%, a 25% reduction brings it to 1.5%, an absolute reduction of half a percentage point. For a high-risk patient with a 20% baseline risk, that same 25% reduction saves 5 lives in every 100 people treated. Same drug, same mechanism, very different absolute benefit depending on your starting risk. This is why understanding your personal risk number, not just the headline, is so important. If you experience side effects on a statin, the most important thing is to talk to your doctor before stopping. Don't just quit. There are several strategies available. Lowering the dose, switching to a different statin, because patients can tolerate some statins much better than others, or using every other day dosing, which works well with rosuvastatin due to its long half-life. Coenzyme Q10 supplementation is often recommended anecdotally, though the evidence for it is mixed. For patients who've had a heart attack, abrupt statin discontinuation has been associated with increased short-term cardiovascular risk. Statins are powerful, but they work best alongside, not instead of, lifestyle changes. A Mediterranean-style diet rich in vegetables, whole grains, legumes, and healthy fats remains one of the most evidence-based dietary patterns for cardiovascular protection. Regular aerobic exercise, not smoking, and maintaining a healthy weight all independently reduce cardiovascular risk. When you combine these with statin therapy for appropriate patients, the protective effect is substantially greater than any single intervention alone. Going into a conversation with your doctor prepared makes a huge difference. Ask what your actual 10-year cardiovascular risk score is. This is usually calculated with a validated tool. Ask which statin and dose is being recommended and why. Ask what LDL target you're working toward. Guidelines vary, but for most high-risk patients, the goal is an LDL below 70 milligrams per deciliter, or even 55. And if you're in a lower risk group, it's entirely reasonable to discuss whether lifestyle changes alone might be trialed first. Shared decision-making, where your preferences and values are part of the conversation, is the standard of good medical care. So what's the verdict? For high-risk patients, those who've had a cardiovascular event, have diabetes, or have a significantly elevated 10-year risk, the evidence is overwhelming. The benefits of statins far outweigh the risks. For moderate-risk patients, the balance still usually favors treatment, especially when lifestyle changes are already in place. For truly low-risk individuals, the conversation is more nuanced and lifestyle optimization should come first. The key word in all of this is personal. This is not a one-size-fits-all decision. It should be based on your risk, your values, and a real conversation with a doctor who knows your full health picture. Before we wrap up, let's bust a few myths that circulate online. Statins do not cause memory loss or dementia. This claim has been studied thoroughly and not supported. Muscle pain, while real for some, affects a minority of patients and is almost always manageable. Some supplements like red yeast rice contain statin-like compounds, but they lack the rigorous dosing, safety monitoring, and outcome trials of prescription statins. And finally, being on a statin doesn't mean you're on it forever. As your risk profile changes, your doctor should reassess whether continued therapy is still appropriate. That's everything you need to know about statins. Clearly laid out, no fear-mongering, no oversimplification. If you found this video useful, please subscribe and hit the notification bell. We publish new medical education videos every week, tackling topics that matter to your health. If you have a question your own doctor hasn't fully answered, leave in the comments. We will read them all. And if you or someone you know is weighing up statin therapy, share this video. Knowledge truly is your best medicine. Take care of yourselves, and we'll see you in the next one.